Well, good afternoon, everyone. My name is Dan Malone, and welcome to our webinar with respect to improving the relevance of drug-drug interaction warnings. Today, we're going to talk about drug-drug interaction reports and how to analyze those reports and what to do once you've analyzed them. So we appreciate you joining us. This work is sponsored by a grant that is being conducted by the individuals on this slide. We have individuals from a variety of different organizations participating in the project. So this is my high school yearbook picture. Anyway, glad that you could join us today. I'm at the University of Utah. I'm professor in the Department of Pharmacotherapy and the principal investigator on this particular project. This webinar today involves some hands-on activities, and on our website, ddi.cds.org, under the first page, you'll see a link to this particular upcoming webinar. And when you click on that link, you'll actually see this information is presented on the screen at the moment. And you'll see two files that are available for download. I recognize that some of you may have blocks with your hospital systems for downloading files, but if you can download those files, we'll work with those in just a minute. Mainly the Excel data is the second link there, and that's the one we're going to work with primarily during today's webinar. We've also put them in the chat. I'm not sure that anybody is, I'm looking to see if anybody's been able to actually open them up via the chat function, but they should be in the chat. So our group has been trying to create resources for meaningful drug interaction warnings. And over the course of the last few years, we've tried to contextualize alerting algorithms to reduce alert fatigue and then disseminate these via our website so that individuals like yourselves and healthcare organizations could actually use that information to customize your systems to improve how alerts are presented and what alerts are presented, and hopefully address the issue of alert fatigue. We'd love to hear about your situation if you've implemented one or more of our algorithms or other algorithms to minimize alert fatigue with respect to drug-drug interactions. You can email us at info@ddicds.org, or at the end of the webinar, I'll also give you my personal email at the University of Utah. So today I'd like to introduce our two speakers for our presentation. We have two talented individuals. I'm surprised they want to be associated with me, but they do, or they have been. And we've continued to work on the issue of drug-drug interaction warnings over the past, well, many years, actually, several years now. So Andrew Romero is a pharmacy informaticist at Banner Health System in Tucson, Arizona. And Andrew is kind of an expert extraordinaire in using Excel pivot tables to analyze medication safety data. So Andrew will be presenting on the first part of our webinar, working with the data and showing you how to answer basically questions that are relevant to trying to tailor those warnings to your hospital system or your health system, such that you're providing the right information to clinicians and others at the time that they need it. Our second speaker is John Horn, who's a professor emeritus from the University of Washington. Dr. Horn has been studying drug interactions for many years and is one of the co-editors of Drug Interactions Analysis and Management, and has actually, I think that book's gone out of print, but John and Phil Hanston have another book in print about the top 100 drug-drug interactions. But anyway, John will talk to us about his experience associated with tailoring the warnings that they receive for drug interactions at the University of Washington. So with that, I'm going to turn it over to Andrew here. And Andrew, I'll go ahead and move the slides forward until you're ready to take screen share.
Okay, welcome everyone. Good morning or afternoon, depending on what part of the country you're in. So as Dana mentioned, we're going to be working with some drug-drug interaction alert data today from Epic and demonstrating how to use Excel to analyze data. So if you want to go to the next slide. So this is going to be focused on the Epic drug-drug interaction report that is a canned report that comes out of Epic. But if you do not have Epic, a lot of these pivot table functionalities are very common that can be applied to any other data set too. So we'll just happen to be working with the Epic drug-drug interaction data. So within Epic, Epic allows you to customize drug interactions by changing the severity of alert. So if we wanted to say that First Data Bank or Multum or one of the other drug vendors says that this is a severe interaction, Epic allows you to go and change that down to mild or moderate if you want. You can also have the ability to change the level of severity that are displayed to different users. So if we wanted to display severe interactions to physicians and we wanted to display severe and moderate interactions to pharmacists, that's something that we could do. Epic also has the ability to suppress alerts within different order sets. So if we say we wanted to suppress duplicate drug interactions within the PACU admission order set, that's something that we can do within Epic. So next slide. So Epic has a couple of standard canned medication warning reports. So this is how you go and generate that medication warning report that we're going to be working with today. So you would log into the clinical administration portion of Epic. Epic does recommend that you run the report either in the report or shadow environment. It's a fairly long report, so you don't want to impact your production environment by running large reports in production. So ideally run it in shadow or the reporting environment. From the clinical administration, you can go to the management options, utilities, orders, medications, and there's a medication warning statistic report. Once you select that report, there's going to be several different prompts that you can fill in. So start and end date is pretty self-explanatory. You'll usually want to run it for 1 month or less at a time, just again, so it doesn't bog down the entire system. There's a skip filtered warnings. You'll want to enter yes, so the report will only display warnings that are actually being displayed to the end users and not including filtered warnings. Skip canceled actions, we will enter a no to include all warnings that are shown to users. And next slide. Hospital clinic name, again, fairly intuitive. You'll want to enter your hospital name. For medication warning type, if you enter the question mark, you're going to see the different choices. There's a couple of different medication warning reports that you can run, such as drug allergy, duplicate drug alerts. For this example, we're going to be focused on the drug-drug interactions. So the report that we will see is focused on drug-drug interactions. For report, we can enter number 1 to generate the medication warning detail report. There is a summary report. The summary report can be useful to look at a very high level. I personally prefer to just enter and use the medication warning detail report and then use the pivot tables that we're going to be talking about shortly to analyze and kind of group that data, because you can answer almost any question you want with the medication warning detail report. A patient identifier, you can enter MRN or CSN, just personal preference. It doesn't matter for the purposes of what we're doing. For external identifiers, you can enter no, and then you'll enter a server location to save the report to. For file format, you will want to save it as an XML report. So then once the report runs, you'll want to download that and keep it on your desktop and open it up within Excel. So that is where we're going to start today. If you want to hit the next slide, Dan, I think. So this once you run the report, this is what it's going to look like. And this is kind of where a lot of people get lost, is because we get a log file of essentially all the drug-drug interaction reports, the date and time, the patient so we just get a big log file of all the interaction reports that have been generated over the last month or whatever time frame you entered. So we're going to look at using some Excel tools to analyze this report and turn it into something more useful. So Excel has a functionality called pivot tables that allow you to sort and group and count data very quickly and answer a lot of different questions relatively easily. So we're going to focus a lot of this webinar on using the pivot tables within Microsoft Excel to analyze this type of data. So we do have a step-by-step instructions within a Word document, or I think it was a PDF document on the website. So don't feel like you need to take copious amounts of notes in order to duplicate this. Feel free to download both of those files and then kind of work through this at your own pace. You are welcome to download the files and follow along. We'll try to go at a pace where people can follow. If you have questions, you can post them in chat. We will also be hanging out for about 30 minutes after the webinar. So if you have certain questions and you got lost, we'll be available for some questions. So with that, I'm going to take over the screen. And you should be able to see my screen.
Yes, we can, Andrew. Thanks.
Okay, so this is the Excel file that we are going to be working with today, and we're going to be just going through step by step and answering some questions with this drug-drug interaction data out of Epic. So we can tell that these are all drug-drug interaction reports. The next column we get is saying what type of an interaction it was. So it's a metoclopramide promethazine interaction. This particular one came up when we were verifying orders. So we can tell what happened with that warning. We can tell if it's inpatient, outpatient, which medications were involved in it, severity, and so on and so forth. So we want to try to analyze this data and pick up some useful trends out of this data. So pivot tables work best if you have a standard Excel spreadsheet without these header rows. So the first thing that we're going to do is select the 3 header rows by clicking and dragging over them. We can right click and then choose delete. So that gets rid of those header rows and kind of prepares it for a pivot table analysis. When we want to create pivot tables, you want to click anywhere within your data. So I'm going to just click in cell A1, but you could click anywhere within your data. We will go to the insert menu within Excel and then click pivot table on the far left-hand side. So once you select pivot table, Excel is going to pop up a window and ask you to confirm some options for creating that pivot table. You should see that Excel automatically selected all of our data. So we have these green selection going all the way around our data. So all of our default options are fine. We will just click OK in order to accept the default options. So when we click OK, Excel starts a new sheet. So I prefer to name that pivot table so it's easier to keep track of where we are. So I'm going to right click on sheet 1 and I'm going to select rename. And I'm going to call this pivot table. So when we create these pivot tables, Excel keeps our original data. So we now have 2 worksheets down here. We have our original data in the data tab, and we have our pivot table within the pivot table tab. So pivot tables consist of 4 different boxes, one called filters, one called columns, one called rows, and one called values. And then we have these pivot table fields. These pivot table fields correlate to each one of the columns that we have within our spreadsheet. So we have a type, description, source. If we go back to our original data, we have a type, description, and source column. So each one of these pivot table fields correlates to one of the columns that are within our spreadsheet. By default, they are in the same order that they are within your spreadsheet. Sometimes that's easier to work with. Other times it's nice to have these in alphabetical order. So for the purposes of this webinar, we're going to change that to alphabetical order. So I'm going to click on this gear icon, and we are going to select the sort A to Z option. So now notice that these fields or columns are all in alphabetical order. Okay, and once these are in alphabetical order, pivot tables work by allowing you to drag these different pivot table fields to these different boxes, and depending on where you drag them, it's going to count and aggregate and summarize the data for you, which makes it ideal for summarizing large amounts of data. So the way that this is going to be structured is we're going to try answering different questions with this data. The first question that we're going to answer is, what are the most common drug interaction alerts that are displaying at our particular site? So in order to answer that question, we're going to find the interaction ID pivot table field. So since these are in alphabetical order, I'm going to scroll down to the I's. We're going to drag that interaction ID from the pivot table fields into the rows category. So I'm just going to drag and drop it from the pivot table fields, and then I'm going to let go of the mouse button when I get to the rows category. This is going to give us a unique list of all the drug interactions that fired over the, I believe this is a 1 month time period. I also should have mentioned that this is synthetic data. So some of the information may not look exactly like real life, but it is with fake patients and time shifted data. So these are all the drug interactions that fired within our 1 month time period. So once we drag the interaction ID here, we are also going to drag that same interaction ID into the summarized values box. So when we do that, Excel is going to notify us what it's doing with that information. So in this case, it is counting how many times each one of those interactions occurs within our original data. So this is essentially how many times each one of the drug interactions fired within the month time period. So these are currently in alphabetical order. We are going to reorder these so the most common alerts are at the top of the spreadsheet. So I'm going to click in cell B4, going to click once to signify that this is the column that we want to sort by. I will then go to the data menu and click this Z to A button to sort it from the largest to the smallest. So when I do that, it will sort the spreadsheet so the interactions that occurred most commonly are at the top of our spreadsheet. So we can tell that ondansetron QT prolonging agents is our #1 alert that fired during this month time period. It fired 5,419 times. Our second most common drug-drug interaction is propofol fentanyl, which fired 2,179 times. So whenever we're looking at this type of data, we're always looking for trends here. And when I see these two numbers, it immediately sticks out that the ondansetron QT prolonging agent has fired over almost, I guess, over double the number of times that our second one fired. So we're always looking for trends like that. So we want to really focus on one interaction. Our ondansetron QT prolonging agents is going to be one that we want to focus on. So pivot tables make it very easy to change what we're focusing on. So we're currently focused, our focus is on which alerts are firing most frequently. Let's say we want to figure out which nursing units have the most drug interaction alerts. So we can drag the interaction ID from the rows and drag it back onto the pivot table fields. So that clears our pivot table. So then we want to look at the nursing units. So Epic calls the nursing units patient department. So I'm going to drag this patient department from the pivot table fields and drag it into the rows. So we're now seeing a list of all the nursing units within our hospital system and how many drug interactions fired for each one of those nursing units. So these are, again, by default in alphabetical order. So if we want to put these in descending order by number of alerts that occurred on that particular nursing unit, we can click in that column. So I'm going to click in cell B4 and then click the Z to A button to sort these in descending order. So here we can tell that our peri-op area has the most alerts at 5,243, followed by 4 Southeast at 4,100. And again, so that's kind of one of the major advantages of a pivot table is it allows you to drag different fields into the boxes here on the right-hand side, and it immediately counts and summarizes that data for you. So it makes it very easy to change what you're focused on. Pivot tables also make it easy to turn that data into a graph so you can graphically identify different trends. So let's say we wanted to take a look at the top 15 drug interactions and turn that into a graph. So we're going to drag the patient department from the rows. We're going to drag it on top of the pivot table fields to get rid of it. And we are going to drag our interaction ID from the pivot table fields and drag it back into the rows. So this is again going to give us a list of all the drug interactions and how many times each one of them fired. If we try to turn this into a graph, or if we try to print this, this is way too long to print out. We have almost 500 rows of data. So it's common for us to want to only display like the top 15 or top 20. In this example, we'll do the top 15. We can right click anywhere in column A. When we right click, we can go to the filter option, and then there's a top 10. So again, that's right clicking anywhere in column A and then going to filter and top 10. So by default, it's going to display the top 10 items. We can change this to any number we want. Usually 15 or 20 items works pretty well if you're trying to put this onto a PowerPoint presentation or print out that information. So I'm going to change it to top 15 and click OK. That gives me a much more manageable list of drug interactions. In order to turn this into a chart, we can go to Pivot Table Analyze. And then there is a pivot chart option on the far right-hand side of that menu. So I'm going to Pivot Table Analyze, Pivot Chart. Once I select Pivot Chart, you can turn this into a variety of different charts. Usually for pivot tables, I prefer the second one, which is called a stacked column chart. So I'm going to select the stacked column chart and click OK. Once we have that, I prefer to have this in a separate sheet. I don't like to have it floating over my pivot table. It makes it too confusing to look at. So I'm going to the Pivot Chart Analyze menu, and we're going to select the Move Chart. And we're going to move it into a new sheet. And also to keep things organized, I like to call this Pivot Chart. So I'm going to rename it Pivot Chart. And I'm going to click OK. So now we should have 3 tabs within our Microsoft Excel worksheet. We should have our original data, we should have our pivot table, and then we should have our pivot chart. So this pivot chart will have some buttons on it. When we're doing screenshots or printing these up, we don't want these buttons displaying. So you can right click on the button and you can say hide all pivot or hide all filled buttons on chart. So that's going to give us more of a normal looking chart. So these are our top 15 drug interactions. And again, when we're looking for trends, our ondansetron QT prolonging agent shows up with a very high bar chart. So that's one that we would really want to focus on immediately. And then we start to get down to ones that have more normal levels of alerts. So the next question that we're going to try answering with this data is how are users responding to these alerts? Are they removing one of the offending drugs? Are they overriding the alerts? Are they just viewing them and not taking any action? So we're going to click back on the pivot table worksheet. And there is a column called warning status. So within our pivot table fields, I'm going to scroll down to warning status, and I'm going to drag that warning status from the pivot table fields to the columns. So when we do that, it changes our pivot table, and we can now see how many times each person or each alert is being overridden, how many times is one of the offending drugs is being removed, how many times is the alert just being viewed and kind of no action is being taken with it. So here we can tell that most of our interactions are being overridden. So out of our 21,000 drug-drug interaction alerts that fired, 18,300 were overridden. So one great thing when we make pivot charts is that whenever we make changes to our pivot table, all that information automatically updates within our pivot chart. So now when I go back to our pivot chart, we can see that we have additional elements here, and the orange color is overridden. So we can tell that for each one of our drug-drug interactions, most of the alerts are being overridden. When you hover over each one of these bars, it's going to give you some details. So we can see the exact value. So 4,929 alerts were overridden. For propofol fentanyl, we can see that 2,028 alerts were overridden. So the general trend that we're looking at here is that for at least our top 15 drug-drug interactions, the vast majority of those alerts are being overridden. Okay, the next question that we're going to look at for our drug-drug interaction data is what provider types are receiving these drug interaction alerts? Are pharmacists receiving most of the alerts? Are nurses receiving the interaction alerts? Are providers or residents receiving most of those interaction alerts? So this again demonstrates one of the functionalities within the pivot tables that it makes it very easy to change what we're focused on. So instead of looking at our interaction ID, I'm going to drag that interaction ID from the rows, drag it back onto the pivot table fields. And we're going to drag the provider type from the pivot table fields into the rows. So I'm going to drag provider type from the pivot table fields and drop it onto the rows. So this again, by default, puts them in alphabetical order. We're more curious at looking at this by which providers are receiving the most alerts. So I want to sort this by the grand total for each one of these provider types. So I'm going to click in cell F5. I'm going to the data menu. And then I'm going to sort these in descending order by clicking the Z to A button. So here we can see that pharmacists are receiving the most alerts. They received 35,482 alerts, and residents are receiving the next highest number of alerts at 4,100. So pharmacists are really where most of our interactions, our drug-drug interaction alerts are being generated from. Again, our pivot chart updates in real time. So if I go back to the pivot chart, we can see that it's now graphically displaying our user types here. And this again makes it look even more apparent that our pharmacists are receiving the majority of our alerts. If we hover over the orange bar, that's the overridden. So the pharmacists are overriding most of the alerts that they are receiving, and they are viewing a smaller percentage of those alerts. The next question that we're going to look at is what are the severity of the alerts that are being shown to these providers? Do these alerts that we're seeing, are they moderate alerts? Are they severe alerts? Are they contraindicated alerts? That's something that we can also distill from our pivot table. So I'm going to click back on our pivot table. Instead of looking at the warning status, I'm going to drag the warning status from the columns and drag it back to the pivot table fields. And I'm going to drag severity from the pivot table fields into the columns. So this will now break down how many contraindicated drug combination alerts we had, how many moderate interactions, and how many severe interactions we had. We can tell that most of them are moderate interactions. So out of our 44,000 total interactions, 28,617 of those are moderate interactions. When we click back on the pivot chart, we can graphically see that pharmacists are still seeing most of our interactions, and the vast majority of those interactions that pharmacists are seeing are moderate interactions. And in fact, it looks like our other user types within Epic are not seeing the moderate interactions. So it looks like pharmacists are currently seeing the moderate interactions, and we have those suppressed for residents, physicians, registered nurses, etc. So when we're looking at this type of data, to me, one of the questions that it would ask, we should be asking is, should we turn off the moderate interactions for pharmacists? And if we did so, it would severely, or it would dramatically decrease our number of alerts that we're seeing within the system. So if we wanted to look at turning off the moderate interactions, the next question is, well, what are the moderate interactions that are currently firing within Epic? So within our data here, we can look at which interactions are currently classified as moderate interactions. So I'm going to click back on the pivot table. I'm going to drag the severity from the columns and drag it into the filters area. And then I'm going to drag the provider type from rows back to pivot tables, because we're no longer interested in looking at it by provider type. And we are going to drag the interaction ID, which is the name of the interactions. I'm going to drag the interaction ID from the pivot table fields into the rows. So notice here, we're not seeing all of our interactions. Excel is smart enough to remember that we previously applied a top 15 filter to these interactions, so it's only displaying the top 15 interactions. For this question, we want to look at all the moderate interactions, so we don't want to look at the top 15. Excel tries to indicate that it's displaying filtered alerts here by this filter icon in cell A3. So if I click on that cell A3, the filter icon, we can select clear filter from interaction ID, and that's going to get rid of that filter, and it's going to show all the interactions now. So these are all interactions. These are not necessarily the moderate interactions, but we have this severity drop-down option in cell B1. So we can change this to just display the moderate interactions. So whenever we have filters displayed here at the top, those apply to everything below it. So we are now only displaying the moderate interactions that are being displayed within our system. So we can tell that propofol fentanyl is our #1 moderate interaction. It fired 2,179 times. Narcotic phenothiazines fired 2,123 times. So if we were to turn off all the moderate interactions within the system or no longer have moderate interactions displayed to our pharmacists, this is a list of the interactions that would be filtered. So we would want to go through and make sure that we're okay with filtering these particular alerts. So if we wanted to take a look at what type of providers are seeing these alerts, we can also do that. Pivot tables allow you to nest or group data within the pivot table. So I'm going to find the provider ID, or not provider ID, provider type, sorry. So I'm going to find this provider type, and I'm going to drag this on top of the, I'm going to drag it underneath the severity filter. So you'll notice when we're dragging and dropping these, there's going to be a green bar that indicates if it's above or below. So I'm going to drag the provider type below the severity. That gives me another filter here. So I can say I only want to see pharmacist. So I'm going to scroll down and select the pharmacist option. So this is now displaying the moderate interactions that pharmacists are currently viewing. So if we wanted to just turn off moderate interactions for pharmacists, these are the interactions that would be suppressed by doing so. And we have a count of how many times each one of those are firing. Normally Excel counts each one of the interactions that is being displayed. We can also change that. So if we wanted to look at it by percentage, we could do that. So if we right-click anywhere in column B, there is a show value as, and we can say % of grand total. So this is now indicating that the propofol fentanyl interactions account for 7% of all the moderate interactions that pharmacists are seeing. So sometimes it can be useful to look at it by percentage. A lot of times I prefer to look at it by the raw numbers, so you have some type of a sense of the scale of the problem. So even though we can tell that this is accounting for 7.7% of the total alerts, I think it's easier in some aspects to look at that by total numbers. So I'm going to right click and go to summarize value or show values by and select the no calculation. So we can also, let's say that we needed to get some more information about turning off these particular alerts, and we wanted to take a look at which clinicians are actually overriding these particular alerts. So I'm going to drag the interaction ID out of the rows. And one of the columns that we have is user ID, or they call it override user. So I'm going to drag that override user into the rows category. And this is giving us a list of which users overrode each one of the interactions. I should have left the interaction ID. So I'm going to redrag this interaction ID and drop it on top of the override user. So we'll watch that green bar again and drop interaction ID on top of that. So this is showing us for the propofol fentanyl interactions, these are the users that are overriding that particular interaction. I can again put these in descending order. So I'm going to click in cell B5 and then click the Z to A. So here we can see that Karine overrode 226 of those interactions, and our user Shantae overrode 215 of those interactions. So if we needed to get some more information about, is this a valid interaction, those would be two good pharmacists to go talk to. When we have information nested, so we have more than one row listed here, we can see that we have a plus or minus sign. So if I click that minus sign, it will collapse the propofol fentanyl interaction and display the next interaction. So our second most common drug-drug interaction is the narcotic phenothiazines, which fired 2,119 times. Karine also overrode many of those alerts, and then this other pharmacist, Mose, would also be a good one to go talk to. So sometimes that can be useful when we're trying to figure out why are people overriding these alerts. We can actually go talk to those users and figure out what their train of thought is when it comes to overriding those alerts. So the next question we're going to look at is what impact is turning off these specific interactions have? And we've already looked at this to some extent, but we're going to demo one other method of looking at that. So I'm going to clear out my pivot table and I'm going to clear out our filters. So I'm going to drag all the information from our filters out of that box. I'm going to drag everything out of the rows. So we're kind of starting back at square one here. We're going to drag interaction ID back into the rows. And for this example, we're also going to drag the interaction ID again into the summarized values box. So now we have 2 count of interaction IDs here. And the reason we're going to do that is we're going to right-click the second column, and we're going to do show values as, and we're going to say % of grand total again. So sometimes it's nice to look at it both by percentage and raw numbers. So we can tell that ondansetron QT prolonging agents fired 5,419 times. That accounts for 12% of our total alerts. So that's one way to look at our impact of turning off different alerts. Sometimes it can be useful to have a % running total here. So instead of just displaying the % of times that each one of these alerts accounts for, I'm going to right-click the percentage and do show value as, and we are going to do % running total in. So once I select % running total in, it's going to bring us to a box. The base field is fine. It's going to show interaction ID. You can just click OK. So this is an interesting way of looking at the data because it starts summarizing how many times each one of the alerts is accounting for. So our top alert is still accounting for 12% of the total alerts. These 2 alerts are accounting for 16% of our total alerts. These 4 alerts are accounting for 26% of our total alerts. So this can be a useful tool because if we wanted to decrease our alerts by 30% overall, we can come here and find that these particular interactions here account for 30% of our total alerts. So there's really only 1, 2, 3, 4, 5 interactions that are accounting for 30% of our alerts. If we wanted to decrease our alerts by 50%, we can find the 50% marker, and we can see that these, I believe it's 18 interactions account for 50% of our overall alerts. So it's a good reminder that oftentimes there's a small number of drug-drug interactions that really account for the majority of your alert burden. So if we either turned these off or adjusted the severity of these 18 interactions, we could immediately decrease our number of alerts by 50%. So that was a lot of information to cover, particularly if you haven't seen pivot tables before, which is why we did make it a step-by-step document available. So it will go through each one of the steps that we just did, show you where to drag interactions, and it also provides that sample data for you to work with. But we encourage you to run your own data and take a look at that information. So the Word document also has some other questions that you can look at. So we could look at what specific order sets are contributing to drug interactions. Are the interactions occurring in the inpatient or outpatient settings? And so it will walk through what do you want to drag into the columns box? What do you want to drag into the rows box? What do you want to drag into the filters and summarized values box in order to answer those type of questions? So again, this is just kind of meant to be a quick overview of pivot tables. So if you haven't seen pivot tables, we wanted to demo how they work and some of the functionality. So, and with that, I'll turn the screen back over to Dan, and John is going to go over some of how they've used some of this data to analyze their alerts at their facilities. So with that, I'll turn it back over to Dan.
Thanks, Andrew. So as I mentioned at the top of the presentation, Andrew's Excel extraordinaire person and learned to analyze this type of data with Excel. Very useful. So thanks, Andrew. Really appreciate that. And again, you can find those materials in terms of the files on our website. And also, once the webinar is completed, we'll get that information uploaded as soon as we can. So our next speaker is Dr. Horn. As I mentioned earlier, Dr. Horn is a professor emeritus at the University of Washington and has been working on the issue of drug interaction warnings for quite some time. So John, how about I turn it over to you?
Great, thanks, Dan. And I'll add my accolades to that presentation from Andrew. I might even know how to use Excel now. That's amazing. So what I'm going to try and do in the next few minutes is give you a little bit of history of what we've been doing at the University of Washington over the years with our drug interactions. And as Andrew's pointed out, the first thing you need to do, I think, is figure out whether you've got a problem with the alerts that you're getting, and using the alert reports is a great way to do that. Now, we, back in about 2005, we're getting ready to implement Cerner in our institution, and we looked at what the DI alerting looked like in Cerner at that time, and felt that we probably wanted to take a little harder look at it and maybe do some modifications so we weren't getting quite so many alerts triggered for interactions. And so we did what everybody does if they're in a big institution. We formed a committee. And that committee, as you see here, was made up of a number of people, most all of them being pharmacists. We had pharmacy IT specialists, because obviously something was going to have to be done at the IT level. And then we had a lot of clinical specialists. We're very fortunate to have a lot of really wonderful specialized pharmacists in our institution, from a lot of services that employ a lot of drugs, as well as drug interaction interests. We did go to prescribers as needed. If we, as a committee, felt that we needed more information about particular alerts, we went to the prescribers to get their input. And one of the things we realized right away was we really needed to have some sort of set of rules to kind of follow as we went along this path. And if you go to the next slide, Dan, you'll see some of the rules that we set up. One of the things we decided was that we were going to show providers and pharmacists the exact same set of interactions. So that made it a little bit easier, because we felt, if we're going to be concerned about a patient receiving an alert or a pair of drugs that we don't want them to get, we want the pharmacist and the provider to see that same alert. We defined our rules basically that any interaction that was going to be interruptive would be what we consider to be a major level of severity. And for us, that means that the risk of the interaction was greater than any benefit that you might get from giving the pair of drugs to the patient, unless you were doing some specific monitoring or other parameters. We won't get into all of that little detail. Since we really couldn't do much in Cerner's database to change things, but we could do, as Andrew noted with Epic, we could change the severity listing. And so that's how we approached this. If we found we looked at the major interactions first, and if we found any of those that we felt didn't need to be alerted, we just changed them to a moderate, and therefore they didn't alert for the prescribers or for the pharmacists, but of course they were still in the database and in the system. Now, the problem, of course, is that that's a very binary way to do customization, but that's the way the systems are set up. They're very binary. You either alert or you don't alert. And that's not a wonderful way to do it. And some of you have listened to some of the other presentations from Dan's group know that we've been working very hard on some algorithms which are a much more patient-specific approach, but we were unable to do that at the time that we did this review with Cerner. So let's go to the next slide, Dan, and talk a little bit about how this all came out. So the way this function is that we went through the database initially. There were only about 8,000 major alerts when we did this, so that only took about a year. It would take a lot longer now because there's probably 5 times that many in the major database almost at this point. And as I mentioned, we reviewed these interactions, and one of the things that we did was we looked at the data that was presented by the database because they had references in there, but we also looked at primary literature, at NDAs, at labeling. We looked everywhere we could to get as much information about the alerts as we could find to make a better recommendation back to the committee, and then making a recommendation to actually change the alert status for that particular interaction. Once we did the primary run through the database, then we had the problem of getting monthly alerts, which, monthly updates. It's not really a problem. It's a wonderful service that Multum provides, but in that monthly update are changes and new alerts. And so unless we figured out a way to keep that under control or review those, we were going to go out of date very quickly as far as our customization went. So the committee just continued on, and we've been doing that now for about 16 years. And every month as the updates would come in, we would go through those. And Dan, if you go to the next slide, I'll just show you a little example of what that sort of looks like. Here's the first row has got the summary data from 3 years, and then the data from 2017 by itself. The number of updates were the total number of updates that came in. And if you just look at the 2017 row, you see there was about almost 58,000 updates to the DDI data. They're very busy keeping this data up to date. Out of that group, we reviewed about 5,300 majors and about 14,000 moderates. And we downgraded majors. Almost 58% of the ones we looked at were downgraded to moderate, and about 6% of the moderates were actually upgraded to major. So that's essentially what we did, and we continued to do that. We have a fairly extensive rule set that we use to maintain all of this. And then we did something which was probably crazy looking backwards, or maybe not, but we decided we'd change to Epic from Cerner. And so Dan, if you go to the next slide, that presented us with a whole new level of interactions to review. And so before we went live with Epic, we looked at a group of alerts that were triggered by Epic in our outpatient, because we actually had Epic running in our outpatient services. So we had a history with Epic, and we did, like Andrew said, we pulled the alerts and we started going through those. And this is a summary of that pre-go live review based on those outpatient alerts. We got a fair number of alerts, obviously, as you saw from the big long list. And again, we just sorted it by numbers and started going through the most common ones. We went through 71 of the most common alert drug pairs, which actually represented a little over 80% of the total alerts that were triggered. Out of that group, there were 6,300 and a few interruptive alerts. And after reviewing those, there were 1,289 left, which was about an 80% reduction in the number of alerts. Now, obviously, that takes a lot of time and effort. We, of course, were fortunate in that we had this history with Cerner for 16 years, so we had a pretty easy way to go back and sort of look, what do we do with Cerner? Can we do the same thing with Epic? And then we went live with Epic, and we let everything sit for a few months while we sort of settled down and got the systems all running well, which actually went quite smoothly, I think. And if you go to the next slide, Dan, you can see what we ended up with after the go live. This time, when we looked at the data, we were looking at the inpatient alerts. So there were some differences, obviously, in the number of alerts triggered in the inpatient setting versus the outpatient. We went through again and looked at the most common alerts. We chose to review 53 of the most common ones. They represented almost 11,800 interruptives. After review, there were still about 9,800 interruptive alerts, 17% reduction. So it's not as big a reduction. And the reason, of course, is that we've already cleaned out a whole bunch of alerts that aren't triggered anymore when we did the outpatient review. So you do eventually get to the point where you have diminishing returns, which is good. If you're trying to limit the number of interruptive alerts to those that you feel are most important, this kind of approach will get you there. The problem with this is still it's just a binary yes, no, and you have to keep it up. So that's our approach, and that's a real quick overview. If any of you are more interested in more details about how we went about this, I'd be happy to talk with you. Feel free to get in contact with me and we can talk about it. And also, if I suspect there's some of you out there who have done something similar in your institution, if you'd like to share that with the group of listeners, I think that would also be very helpful. So with that, I will turn it back to Dan. Thank you.
Thanks, John. I appreciate that. And yeah, we have a few minutes before we reach the top of the hour. And as Andrew and I have indicated, we'll go ahead and stay on past the top of the hour for those people that have questions about either the Excel exercise or any of the other materials that we've presented. So I'm looking at the chat at the moment. I don't see anything, but if anybody would like to unmute themselves and discuss what they've been able to do with their organization, feel free. I think we've given them permission to be able to do that now. I'm just double checking things. So, oh, I'm sorry. I'm just looking. I see a couple chats coming in. So one individual talks about the issue of route. So route is a really challenging issue with the systems currently. And I don't know of any canned mechanism within the current systems, either the Multum or in Epic to filter on route. But I'll let others maybe jump in on that question. I'm not sure that there's a way to do that. So anybody have any experience with trying to filter on route that they want to talk
Dan,
about?
I don't think you can do it either. And it's really a good point because there's lots and lots of examples where route is very important. Not only the obvious ones like non-systemic routes of administration, but also, for example, drugs with high first pass elimination have very markedly different interaction potential when you give them orally versus parenterally. So it's important. It's there's no easy way to do that if it hasn't already been done by the database providers.
Yeah, and there was another question about how did you track your individual alert changes? So, John, you want to try to get onto that question?
Yeah, one of the members of our drug interaction committee basically keeps track of all that stuff, and that happens to be the pharmacy, the safety pharmacist, and so that was something we obviously had to do. We keep track of what's changed. Multum actually keeps track within the database of any changes you make, so that they don't get overwritten later on. So we did that, and as I said, we have a set of rules so that when we come, if somebody brings out a new 3A4 inhibitor, we have a list of drugs that are 3A4 substrates that we're going to alert for any 3A4 inhibitor, and so we can work that way as well. But you really need to keep track of all this stuff. It's a pain, but there's no simple way to do it other than just we just fill out spreadsheets. Basically, is what we do, so we can find the stuff easily.
Yeah. A few other questions that are coming up, so I'm trying to get to them all here. So with respect to hidden alerts or hidden by system settings that might be clinically significant, has your organization, John, gone back and looked at alerts that you may have suppressed and then look to see if there's any implications for that?
You bet. Yeah, I think one of the things that everybody should keep in mind if you're going to do this becomes a forever process, and you really have to treat this as a living thing because data changes, and if you don't keep up with the data changes, You're going to be alerting for things you shouldn't be alerting for, and you'll be bypassing things you should be alerting for. So yes, we do watch that. We also look at all the drug-related events that get, called to attention in the hospital and come in through the emergency room to see if there's anything in there that is related to alerting that we should either be alerting on that we perhaps aren't alerting on. So yeah, we do that. We've been pretty darn fortunate that we just don't see much of that. So we're fairly happy with the fact that the alerts that we have downgraded have not led to any problems in patients. We just haven't seen evidence of that. You can never get to zero. You have to keep that in mind. You're not going to get complete zero, but that's not the goal. The goal here is to be alerting for alerts that have a high likelihood of causing problems, and don't alert for alerts that have a modest or low likelihood of causing problems.
And that is one example when you're running the Epic medication warning report. One of the prompts there is to skip filtered warnings, and in our example, we had entered yes, so the report that only shows warnings that are displayed to users. But that would be an example where you may want to include no if you're specifically looking to see if some of the warnings you have filtered should actually be shown to users.
So another question, and this is more towards Andrew. Can a warnings per order calculation be gleaned from the file? Is that possible, Andrew? I know that Epic produces some general statistics about how many warnings are fired per order, but I'm not sure that that's gleanable from the data file that you worked with.
Yeah, it really is better to use the summary report for that. You could potentially calculate that, I think, from the detail report. The report does have the order IDs, but it includes the order ID of every order that was interacting. So if you have a famotidine order and an atenolol order, it's going to include both of those order IDs within that column. So it's not necessarily giving you like this is the order that was being entered, and this was the interacting drug medication. So it would really be better to use the summary report if you're trying to do that calculation for there's 5.3 alerts on average displayed per order.
Great, thanks, Andrew. So John, a couple of people have asked how much time you've spent loading, reviewing, I guess the changes you've made, is what the question is. And then another kind of question I'll kind of lump in here, how often do you recommend going back and looking at what you've done? Do you do it annually? Do you do it biannually? Do you do it monthly, et cetera? A little bit of information about that process would be useful, I think, to our participants.
Yeah, well, I'll answer the second question first. Our committee meets monthly, and so usually, and so we have sort of a continuing ongoing review process going on, and obviously we get input from either pharmacists or prescribers who are taking care of patients who have questions about alerts that either are or are not being triggered. So it's a constant feedback from our users. I can't answer the question of how long it takes to enter the stuff because they don't let me do that. They actually have IT people that do that. And so I don't know how long it takes. Although, the IT pharmacist on our group, I don't think he's on the call, but if he was, he probably could answer the question. But I don't know. Apparently it's not a incredibly long period of time, because I know after we went through the Epic pre-live, I think they got the stuff entered over a couple of weeks' time. I don't think it took very long. And I don't know how much time they actually devoted to that.
Thanks, John. So we've reached the top of the hour. I want to let individuals know that we'll have the materials from today's webinar posted up on our website as soon as we can. And as a part of this series, you can go back and review previous webinars that we've conducted about tailoring warnings. So if you're doing like best practice alerts in Epic, you might find some of those tools useful. And also, if you are contextualizing any of your warnings, we'd love to hear about it. You can send us information back at our email info@ddicds.org, or you can reach me, dan.malone@utah.edu. We'll go ahead and stay on the webinar for a few minutes but, to answer any other specific questions people might have about the Excel analysis, what have you. But for purposes of recording, we'll go ahead and end it here. Thank you very much for attending, and we look forward to having you attend one of our next webinars. Have a great day.